So, coming up next, coming all the way from Melbourne in Australia, is David Anderson. So he's the medical director of Ambulance Victoria, which covers, I think Victoria covers an area the size of France or a bit bigger. Just a touch smaller than France, but it's a small provincial ambulance service, yeah. He's the associate professor at the Department of Paramedicine at the University of Monash, and he trained originally as a paramedic in Auckland, and then as a doctor in Auckland, and now practices ICU at the Alfred. Again, another provincial hospital you'll never have heard of, but running on from yesterday, where we talked a little bit about defibrillation and DSD, we're going to go for a little bit more into the science of defibrillation.
Thank you. MAD is a hard act to follow, especially when I'm going to be doing a bit more hardcore science. I don't have the pointer. I did forget to turn. There was a request to turn up the microphone. I'll hold it closer to my mouth. Is that all right? So yeah, Matt's a hard act to follow when he's talking about cute animals and the history of science. I'm going to talk a bit more about some more modern science, and there's going to be, unfortunately, a few graphs in my slide. I'm going to talk to you about a clinical trial that we did in Victoria recently. And a little bit of it's about defibrillation and about what the future of resuscitation might look like. But really, mostly, I'm going to talk about the challenges involved in conducting research in the pre-hospital environment, which I think is something that applies to any of us, whether we're researchers or clinicians in this environment. In Australia now, it's quite normal when you start a talk or a presentation or a meeting or a conference like this to acknowledge that Australia has been populated by Aboriginal people for millennia. They're the longest continuous surviving population in the world. And we now normalize recognizing their contribution. And although I don't have to acknowledge the Aboriginal people when I'm here in Switzerland, I think it's the right thing to do, to acknowledge that I live, work, and play on unceded Aboriginal land. This talk was prepared on the land of the Djajawarrung people in central Victoria. And I think it's important for all of us, any of us who live in a colony or a former colony, to acknowledge that almost certainly the Indigenous people whose land that we're living on have almost universally poorer health outcomes and die 10 or 20 years before us. And it's good for us to do whatever we can to address that. As we've already heard, Victoria is the second smallest state in Australia, still just under twice the size of the UK, much bigger than Switzerland, although that's not difficult. In Victoria, our population's just under 7 million, about 5 million of whom live in the capital city of Melbourne. We have one single statewide ambulance service, Ambulance Victoria. We attend about 1 million calls a year. We have about 5,500 paramedics, of whom 500 are critical care paramedics. We've had critical care paramedics in Victoria since 1971, so we're one of the oldest programs in the world. And we attend just shy of about 8,000 cardiac arrests a year. And these are arrests where we actually commence resuscitation. So these aren't dead people, these are where we're starting resuscitation. So that gives us an opportunity in Victoria to use our databases and our research to look both retrospectively and prospectively at how we can do our bit to improve cardiac arrest survival all over the world. Size isn't everything though. What I think makes Ambulance Victoria a very special service, the special sauce for us, I suppose, is our research. We're a very research-focused ambulance service, and we like to tell ourselves that everyone in our organization is passionate about and committed to research. As we get to the end of the talk, you'll see that that may not be quite as true as we think, but certainly at the top levels of the organization, we are incredibly committed to putting out high-value, high-yield research to improve pre-hospital care. And really importantly, almost all of the trials here, plus many of the others we do, are led by paramedics. So we're leaders in paramedic-led research, which I think is really important. And that commitment to research and that commitment to clinical excellence allows us to have numbers like this. So this is our Utstein survival in Victoria. For those of you not aware, the Utstein comparator group is a way to benchmark ambulance services and resuscitation systems against each other. Because some ambulance services will start resuscitation on people in asystole and some don't. Some transport everyone to hospital, some don't. So it's good for us to have a way to have a level playing field to assess each other and see how we're doing. So the Udstein comparator group is bystander witnessed arrests that are VF or VT. Theoretically, the survival in your Udstein group should be 100%. There's no reason why in a perfect system you can't have a 100% Udstein survival in the bystander witnessed VF and VT arrests. We're trying to get there. Our Udstein survival, as you can see, peaked just before the pandemic, now sits around 34%. That's in the top 5 in the world. We want to be number 1, and we will get there by doing more research. Of course, a single line like this doesn't tell the whole story. We know, it's drummed into us, that cardiac arrest survival decreases over time. This is some data that one of our boffins has put together, looking at how cardiac arrest survival deteriorates in the average patient. Now, you can see what the average patient is on the slide there. This is a patient we're all familiar with. Any of you who's done more than a few days of pre-hospital care is familiar with a patient like this. And what you can see is that there's a generally linear deterioration over time, although a slightly sigmoid-shaped curve. What you should also note is the red line across the bottom there, the survival from asystole, which is pretty bad. So I guess the question we have is there anything we can do to change the shape of these curves so that more patients are likely to survive in a time that an ambulance might reasonably arrive? And we've spoken about the chain of survival for a very long time. I was really pleased, and my Alfred colleagues will be particularly pleased to see that there was a chain of survival put up during the talk yesterday that contained ECMO in it already, because I always have to add it on to appease my Alfred mates who think that ECMO should be part of the chain of survival. I don't think it should. But you see, ILCOR has changed the shape of the chain of survival and increased or decreased the size of each link based on the ability to influence change in those areas through research, public education, and bringing clinicians on board. And the smallest link in the chain is defibrillation, because it's presumed that there's not much we can do to improve defibrillation. It seems either a pretty binary thing. You're either successfully defibrillated or you're not. For the rest of this talk, I'm going to challenge that assumption and ask whether we can make that link in the chain bigger and do something to make defibrillation more effective. Any of you who, like me, are from an anesthesia background may well recoil in horror at seeing a diagram like this. You've probably asked to draw one in your primary exam. If I'd been asked to draw it in my primary exam, I'd have just got up and left and become a dermatologist. But this is how a defibrillator works. It's 2 circuits, a capacitor circuit to generate the large amount of energy required to defibrillate the heart, and then a patient circuit to bring the electricity around the body. And you can see there's a very important factor in the patient circuit, and that's the patient. And that's a big variable factor in how a defibrillator works. We can have manufacturers making the best defibrillators in the world. You still have to attach them to a patient, which is going to inevitably increase a degree of variability into how well it works. So we've been asking the question, can we do something to decrease the impedance in the patient and therefore theoretically deliver more energy to the heart, which would increase the chance of a successful defibrillation? The QR codes on my slides, by the way, are a link to the research. I wasn't smart enough, like the people yesterday, to put them all in one big QR code at the end, so I'll do that. I'll remember that's something I've learned for next time. So we do know from cardiology literature in patients undergoing elective cardioversion for atrial fibrillation that thoracic impedance is directly related to BMI, which kind of makes sense. If the pads are further apart and have to travel through more fat, which doesn't conduct electricity particularly well, to get to the other side, less energy will be delivered to the heart, and defibrillation is less likely to be successful. And it turns out that over the last 10 years or so, the cardiologists, are there any cardiologists in the room, by the way? Oh, there's one in the third row. Oh, no. The cardiologists have just been doing this thing without really telling anyone to try and fix this impedance problem. They've been pushing on the defibrillation pads to push air out of the lungs, push the pads closer together, squish the fat, and decrease the impedance. And they call that manual pressure augmentation. And so the first I heard about this, I thought, well, that's interesting, because we kind of used to do this. So I started in ambulance in the late 90s, and this is some of the equipment we used to carry in the ambulance when I started. Some of it might look familiar to some of you, and for the younger ones, you might think, what on earth were we up to? But down on the bottom there is an old Life Pack 10. Trusty old friend, weighed about 25 kilos, I reckon, 3-lead ECG and nothing else, but it had paddles. And you pushed down hard on the paddles, and you looked really cool, and you defibrillated the patient. And then around the turn of the century, paddles just went away and were replaced by big sticky pads, which seemed easier, but have we lost something by doing that? And the answer might be yes. So you can see here, these are some data again from cardiology literature showing that not only obviously more energy leads to more successful defibrillation, and that's why we generally don't do gradually increasing shocks. We just start at a high energy now. But you can see that active compression versus just normal defibrillation or cardioversion is more likely to result in successful cardioversion. And this has been borne out in the clinic as well. Places that have changed to routine manual pressure augmentation for cardioversion have higher successful cardioversion rates. All a bit of retrospective research. There's been a small randomized trial done in Melbourne. Now this is, to be critical of cardiologists, this is a pretty complicated randomized trial with like a double crossover technique. But basically what they did was they randomized the patients to either standard pad placement or AP pad placement, and then randomized them again to either paddles or pads. And they showed something really interesting. The first thing they showed was that at the start of the trial, in the run-in phase, or using their retrospective data, their success rate for elective cardioversion was only 30%. When they used paddles, they were more effective than pads, and that kind of makes sense. The surprise came when they found that manual pressure augmentation was more successful than paddles, because it was presumed it would be just the same. The other surprise came when they found that vector change, AP versus standard placement, made no difference, because everyone kind of presumes that it should. They found that when they used manual pressure augmentation, regardless of the pad position, the success rate went up to 80% successful cardioversion. And there's not a lot of data here. This is a world's worst meta-analysis, two studies there. But if you're an optimist, it does show that there probably is at least a hint of benefit from manual pressure augmentation. Relevant to what we were discussing yesterday, though, around double sequential defibrillation and vector change as a technique for refractory VF, certainly in AF, and remember this is in AF, it does appear that changing the pad placement doesn't make any difference. And this has actually changed my practice. When I have a patient in the ICU we're going to cardiovert AF, or they've got a big anterior STEMI, or they're having runs of ET and we're worried that they're going to arrest, I would previously ask the nurses to put pads on front and back while we had the chance. I don't do that anymore because it appears it doesn't make a difference. It's perhaps one of those dogmas that just keeps getting carried along. Anyway, one of my colleagues, Dion Stubb, who's our deputy medical director, and he's a cardiologist, he was chatting to Alex, the author of the study we just saw there, and said, well, hang on, this is a really good study in AF. Why aren't we doing this in VF? Why don't we give it a crack? And obviously this makes sense. The same reason that manual pressure augmentation should work, or does work in AF, it should work in VF. It will decrease the lung volume. Air doesn't conduct electricity well at all, so you push air out of the lungs. It will decrease transthoracic impedance and should increase energy delivery to the heart. So before I started at AV, the team involved in this research, I came in halfway through, devised this trial to do a pre-hospital feasibility study and then randomized controlled trial of manual pressure augmentation. And they started talking to paramedics about it, and a not very surprising question came up every time they mentioned it. Is this safe? This doesn't seem right. And the answer that the researchers would give would be, of course it's safe. We do it in cath lab all the time. There's never been a serious adverse event documented. And then the paramedics would go, but ever since I started, I've been told not to touch a patient during defibrillation. Like that's a thing that members of the public know. You make sure that you're looking at the camera and that your shirt's slightly undone and you put the paddles on and you say, stand clear. People know that. So during the feasibility phase of the trial, there was some industrial challenges with paramedics saying, no, really, this isn't safe. We want you to do something about this. And the state workplace safety department came in and said, look, it seems okay, but why don't you do some lab research just to prove that it's safe? So they did. So to prove that manual pressure augmentation is safe in the pre-hospital setting as opposed to the cath lab setting, they popped down to the butcher and got a pork shoulder and defibrillated it several hundred times under different circumstances. So you can see there, they used a fist on the pads, open hand on the pads. They also demonstrated hands-on CPR, which is something that people have been talking about for a while. They had their fingers accidentally touching the patient to demonstrate, overhang of the fingers on the pads. They did it with one pair of gloves, two pairs of gloves, no gloves. And my favorite, on a couple of occasions, they did it in paramedic cargo pants that had been saturated in water to simulate, I don't know, a hot, sweaty environment or wetting your pants, I suppose. And what they showed here in the graph on the right there is that the energy transfer, so the zones there, zone 1, 2, 3, 4, zone 1 is you feel a little tingle, zone 2 is you get a little jolt, zone 3 is you get a big jolt, and zone 4 is it will potentially stop your heart. If you were wearing only one pair of gloves, the study mandated two pairs of gloves. If you were wearing only one pair of gloves, everything was in zone 1 or 2. If you're wearing two pairs of gloves, pretty much everything was in zone 1. Everything above zone 3, everything above zone 2 was not wearing any gloves at all or having wet pants. So they were able to show that the latex gloves and people's pants were pretty successful at preventing any energy getting to the heart. So then we went out and did it for real and showed, this was the first patient that we did, and we used the defibrillator to measure the impedance in the patient and showed that as soon as you put manual pressure augmentation on, you decrease transthoracic impedance, which was not unexpected. And importantly, the paramedics didn't feel any perceptible current, so that led us into a clinical trial. The Augment VA trial in adults, in VF or VT, does manual pressure augmentation compared with standard ACLS, improve survival to hospital discharge, which is the most, well, I would argue that neurologically intact survival is the most meaningful measure, and that was one of the secondary outcomes, as well as, ROSC, successful cardioversion, etc. Randomization was pretty simple, because randomization can be quite challenging in the pre-hospital environment. We equipped all of our crews with different colored shoulder straps for the defibrillators. If the first arriving crew had a blue shoulder strap, you were randomized to the control group. If the first arriving crew had a red shoulder strap, you were randomized to manual pressure augmentation, and that's how we did it. We taught the paramedics two techniques. One is with the clenched fist on the pads, and one was the open hand on the pads, pushing with the thenar eminence. And we put these posters up all around our ambulance stations to remind staff of the safety factors involved and how to effectively perform it. And we put some no-nos. We said, don't do this in a hot, wet environment. Wear two pairs of gloves. And we gave some advice on make sure your knee's not accidentally touching the patient. And after the first 100 or so patients, we surveyed the paramedics who were involved. And it was looking pretty good. So we surveyed 96 paramedics. Only one of them felt a perceptible current. But despite that, that one person would still do it again. So all of them said, I would do this again. And when you see numbers like that, you think, oh, we're really onto something here. But then the next piece of data was this. This was how many patients who were potentially able to be randomized were. So actually, very few paramedics were participating in this trial. There was something still going on that was making people not want to participate in the trial. And then we were about 2 or 3 years into the trial. We'd randomized 300 or 400 patients out of the 1,500 we were planning to randomize. And I woke up one morning to this. So a paramedic had received a very perceptible shock and recoiled off the patient in shock. We made the decision that day to halt the trial while we got the Data Safety Monitoring Board and WorkSafe to investigate. I think it's fair to say this generated a fair bit of media in Victoria. It was pretty mixed, actually. And I did one interview where I was expecting to be grilled by a very competent, well-known journalist, and he was mostly just fascinated that we were doing this research and asking me lots of questions about it. So I think it's important to recognize that even when things like this happen, the public, I think, still accept and understand that we have to do research to get better, but of course we have to be safe. So this sent us back to the drawing board, and we thought, well, what have we done here? What's the problem here? And as time has gone on, it's become pretty clear to me. There's been two things that have happened. The first is this. This is the first defibrillator. So Claude Beck invented the defibrillator in 1947, and this is it. So for 80-odd years, we've been using defibrillators, and as I alluded to earlier in the talk, we've been telling people quite explicitly not to touch the patient during defibrillation because it's not safe. And then all of a sudden, you're a paramedic, you show up to do your job, you log on to your email, and there's a video in one of your emails with some guy saying, no, it's fine, touch the patient. It's okay, you'll be fine. And so I think we seriously underestimated the effect of decades and decades of training. You know, one of the first things you learn as a paramedic is safety first. And one of the first skills you learn is how to defibrillate someone and how to do that safely. And I think we, you know, in retrospect, we really underestimated how important that was. The other big factor, I guess, was this. When we started this study, this is what resuscitation looked like in Victoria. So we rolled out the study during the pandemic, in between waves. Well, we didn't know it was in between at that stage. We thought it was over. Paramedics were already focused on their own safety in many other ways, and we were asking them to add one more thing. So I think in retrospect, you know, we probably should have waited as long as we could and done this after the pandemic. So where does manual pressure augmentation sit now? It's unlikely, I think, that we'll be able to restart the trial because so much water's gone under the bridge now. But we're pretty confident. I think we've established that this is definitely feasible and plausible that it should work. And now we need to see if there's a place that it can fit in pre-hospital care. And as we spoke about yesterday, there's a lot of research going on in pre-hospital care in cardiac arrest at the moment. There's a lot of cool stuff happening. We spoke about the DOSE-VF trial yesterday, and most of you will be aware of that, the trial of dual sequential defibrillation and vector change, which showed, you know, there were some people comment on the fact that the trial was perhaps a little underpowered, but still shows an interesting result. And in Australia, you know, where our national or our binational resuscitation council is looking at introducing this as an option for refractory cardiac arrest, and one ambulance service in our region has already started doing it. You know, we've just done a feasibility trial of pre-hospital ECPR in Victoria. Again, something else that sounds utterly bonkers, but does seem to have a place for some patients. Some of you will be aware of this trial of head-up CPR. If I could have put more question marks on that picture, I would, because I think this is something that's purely hypothesis generating and nothing else. But manual pressure augmentation has to be in the mix with all this other stuff, I think. It's something that I think we've shown is feasible. In the right circumstances, I think can be done safely. And we need all the options we have to do whatever we can for those people who are in refractory cardiac arrest, the ones that, you know, the father of intensive care, Peter Safar, would refer to as the heart's too good to die, to try and, you know, successfully defibrillate those patients. So I'll leave you with that question: where might manual pressure augmentation fit in? And I'm very happy to answer any questions, and I look forward to catching up with you all over the rest of the week.
Thank you. That's really interesting. And I think it's doubly interesting because I know what some of the other talks are coming soon. Questions from the audience? I'll come to the front early.
Morning. Thanks very much. My question is, do you think the pressure augmentation has to be manual? And could we get around some of the anxiety and stress around safety that you described by using something that isn't a person?
Yeah, I'm sure we could. Absolutely. So the question was, you know, does it have to be manual? I'm sure there's some gizmo that someone could come up with to do it. I should say, you know, we're very, people at the back from the Corpulse, cover your ears, we're very anti-mechanical CPR in Victoria because our high-performance CPR is already so good. So we're anxious about any toys that might interfere with that. But yes, I think, you know, there's certainly a role for mechanical CPR. There's certainly a role for some device to allow manual pressure augmentation to be done more safely.
Question here about the preliminary data you have from your trial. What does it show?
It's still being looked at and will be published at some stage. So the timing just didn't quite work for me to tell you what it shows. But I would say, you know, we're always pretty wary to look to publish underpowered research because you never quite know what you're going to find. So I think all that I'm happy to say at this stage is that it's definitely feasible.
Cool. Any other questions? Well, so soon we're going to talk a bit more about some of the concepts you talked about in terms of head-up CPR. And this afternoon we'll be talking about pre-hospital ECMO as well. So I think this is one of the great things about conferences like this that generate the questions and generate the discussions. But thank you so much. That was absolutely brilliant.